Gracias.
Oh. Well, at least I tried.
Danke.
Yeah. Absolutely. I can't see the killer. Yeah, I have it here. Ah, there you go.
It's just probably. It's just split screen.
Oh,
Yeah.
okay. You just need to download one more.
Yeah. I'm just here to make sure that everything's okay.
Very nice of you. Thank you. Yeah, trailer is and I'm looking for it. Download. I know. Oh, you were one of them. No. But we still need to refresh it. Download. No, I downloaded it already, so.
You want to eject it first before you do that.
Life's too short for that.
A very stupid question. I just downloaded something, and where's the download folder?
For any other folders you're looking for, you go. That's not a stupid question. Yeah. Any question that's an intelligent question.
So we'll move on. We'll get to the more involved part of the meeting. We'll talk about more complex procedures. We kind of covered the basics. And it's my great pleasure to have Bill Taylor from San Diego here, who's going to talk to us about lateral surgery, single position lateral surgery. And Bill Taylor is very, very involved with the Society for Minimally Invasive Spinal Surgery. He's really a leader, one of the key individuals who put that society together. So he's very involved with research, clinical practice, of course. And I'm also looking forward to tomorrow when you're talking about the value of a good society for MIS surgeons. But for now, we'll hear about single position lateral surgery. Thanks, Bill, for being here.
Thanks, Roger. Shockingly, we have 4 people from San Diego here, I think. 3 or 4 people, at least, from San Diego. I don't know why people decided to come to New York in December. More involved, bringing the weather with us, more involved. But I'm just going to tell you, this talk is going to be the most important thing that you guys hear in the next 2.5 days. There's nothing more important than that. And Louise is laughing at me, but his picture here is right here as I'm standing with him. And at the end of this talk, you're going to say that shockingly, Louise has done it again. And I'm talking about single position surgery only because that's how it kind of got started in this new technique. What I'm really going to be talking about is prone transpsoas. So lateral surgery, lateral interbody fusions in the prone position. And Louise and I have been doing that for quite some time now, and it evolves from single position surgery because single position surgery in the lateral position was designed so we didn't have to flip the patient back and forth. And what we've done now is we have developed a new technique to do lateral in the prone position so you no longer have to flip the patient. Positioning is much easier, and you can work simultaneously, posteriorly, and in the lateral position. And you're going to also see from the early data we have that you're going to increase lordosis in that. So the one picture there is us sitting while we're doing the lateral surgery, and that's Louise and I standing there after one of the first cases. Lateral interbody fusion has a long history now, and the fact is that it started and has continued to advance. There's lots of good reasons why we do lateral interbody surgery. Excellent fusion rates, lower complication rates, less blood loss, short hospital stay. Every reason that we do minimally invasive surgery is embodied by lateral surgery. Natural tissue planes. So I'm not trying to convince you that you should do lateral surgery, although it's great for deformity, and you'll hear from Dr. Mundis in a little while about anterior column releases and other things. But the overwhelming fact remains only about 20% of us are doing lateral surgery. So we have a long history. We've got an excellent literature. We have techniques and well published, but only 20% of spine surgeons are doing lateral surgery. And why is that? Questions about neural complications. People don't want to rely on indirect decompression. They don't want to flip the patient back and forth. They're not willing to do new techniques. And the problem with flipping the patient back and forth is that it has forced us to do things that we wouldn't normally do. So the question I always get asked when someone's in the lateral position is, well, do you put on a lateral plate? Do you do a standalone? Do you flip the patient over and put in pedicle screws? And we've made that decision-making process much, much more difficult than it needs to be. And that's a problem because we know that posterior pedicle screw instrumentation is the gold standard for fixation, and it prevents subsidence, it prevents loss of correction, it enhances your deformity correction, and you have better results with it. So single position surgery became the idea that we'll put the patient in lateral and then we'll put pedicle screws in the lateral. I was talking this morning to someone and I said the basic tenet of this surgery is that it's much easier to do a lateral surgery in the prone position than it is to put pedicle screws in a lateral position. If you look at the literature, about a 5% breach rate, 3% misplaced symptomatic pedicle screws. They're not recommended more than 2 levels. You really can't get as good a correction as you can in the prone position, and you really shouldn't use it for more complex procedures. Single position surgery is well accepted in the literature, but very difficult to do from that setting. So what did we start doing? We started doing lateral in the prone position. You can see us standing there doing that. Why? Avoids a flip. Use easily to position the patient. You get increased lordosis from the prone position. You'll see a couple stats in the end are increasing lordosis, which we get from just turning the patient prone. All the guys doing posterior big deformities have a big advantage over lateral deformity correction because you put the patient prone and it makes a huge, huge difference. You can work simultaneously. I'll show a couple cases at the end, and basically what you're able to do is pedicle screw instrumentation, laminectomies, releases posteriorly at the same time you're doing your anterior inner body fusion, which gives you large cage, good distraction, good fusion rates, all the reasons why we do lateral surgery. The real reason that some people don't do lateral surgery is neural injuries. Although this is not about neuromonitoring, I can tell you that when you're prone, it appears clearly based on our MRI studies that the lumbar plexus and the psoas muscle moves posteriorly with extension of the hips. And in fact, we improve the position of the psoas muscle when we place the patient prone to be able to do a lateral position, which alleviates some of our concerns at L4-5. You must be doing triggered EMG for the approach for the lateral surgery. I just keep reiterating that every time. I still go to meetings and I hear people say, oh, I don't really need, I directly look and I do other things, but you should do triggered EMG. But the piece that most people are missing is that once you have your retractor deployed and you're compressing the nerve root and you have a safe working corridor, you need to have another neuromonitoring to identify the health of the femoral nerve during that time. And what that is saphenous SSEPs. Saphenous nerve is the terminal branch of the femoral nerve. It's the only sensory nerve. You absolutely can very, very well do SSEPs of the saphenous nerve, which gives you direct correlation to the health of the femoral nerve during the procedure and during compression. There's an excellent automated device out now called SafeOp that gives you not only nerve integrity, but identification and dilation. So you get both triggered EMG and automated saphenous SSEPs while you're doing the procedure. How do we do prone surgery? It's really pretty simple. You can either sit or stand when you do it. We position the patient in the usual prone position with a standard OSI table. And then if you want to sit down, we rotate the bed after we operate just a little bit, about 15 to 20 degrees, or you can stand. Dr. Pimenta likes to stand, and I like to sit during the surgery. And maybe it's because I haven't run as many marathons as he has. I'm not in quite as good a shape. Case experience, we absolutely have a good case experience already. We've done over 100 cases with the group combined. These are the first 20. We wanted to do the first 25 cases. The fact is that we have really about 20 minutes from intubation and positioning to surgery. So once the patient's ready to go, it's much, much quicker, about half the time. No flip, no repositioning time, and we get simultaneous posterior decompression. No real complications. One small hematoma seen only by CT. A little bit of upper leg pain as expected. We had one person with some ipsilateral leg weakness, which recovered pretty quickly afterwards. But really what you get is alignment. You get increased lordosis. The fact is that if you're doing it in the lateral position, you get less than half of your cage to global lordosis, and you really have difficulty doing releases. So what happens now is that with a 10-degree cage, we're getting about 7 degrees for each cage. That's without any release or anything done posteriorly. So in fact, you don't need anymore a 20 or 30-degree cage to get a huge correction. You can now easily do a posterior release at the same time. And you can achieve much more than that. This is the first 20 cases, and we've gotten a lot better at positioning. So you really increased lumbar lordosis with a similar thing. The one other reason is navigation. So it's very easy to put an array on the spinous process when the patient's prone, and you can do your whole lateral and your whole posterior procedure with navigation, and then robotics is certainly going to follow. So navigation becomes much easier both for doing the lateral and the posterior aspect. And you just put it on the spinous process. Someone with locked facets, you're not going to get indirect decompression. So we have to go back and do a direct decompression in that spot, which makes it really easy in the lateral approach when the patient's prone to reduce their facets. And that's with facet disease. A long segment scoliosis, just an adult degenerative scoliosis, 4-level scoliosis. Excellent correction at each level. Nice lordosis. 10-degree cages, and we're getting for each cage almost 10 degrees in this position. So you're really getting what you put into it for global lordosis, not just segmental. Facet releases, this is a case that we had where someone clearly put the screws into the disc space and through the nerve root above. You have to take those screws out. The person really has a flat back. We need a good correction at the top. So now we've changed this into a surgery where we can take the person while they're prone, take out the pedicle screws, do our inner body work, do a distraction, release the facets in the back, and we got about a 22-degree correction for that, and that's really what's nice. L5S1 becomes easier, TLIF at 5.1 in the prone position, and in the prone position, lateral at 4.5, which I think is excellent. So what do we like about prone transpsoas? Number one, simultaneous procedures. You can do anything you want in the front and the back. Psoas appears to move posteriorly for the people that are concerned about neuromonitoring, but I couldn't stress enough, use saphenous SSEPs for nerve health and triggered EMG for approach, and it allows for easier decision-making. All of a sudden, we don't have to decide, do I do a standalone? Do I put a lateral plate on? Do I take out the instrumentation posteriorly? We've just allowed everyone to do that. Navigation and robotics, I think, are going to become much easier in that situation. So I went over a little bit on time, and I think you can see why I think this is the most important thing that we're going to talk about all day long today. Maybe Dr. Hartle won't agree with me. Thank you. I'll leave 10 minutes for discussion if we have any.
Well, we'll need it. So thanks. This was certainly unexpected, an unexpected presentation, but I think really challenging, really good. It makes me wonder. First, you make us do everything lateral, Luis, and now you're turning the cards on us, and now we got to go back into prone. Any questions or comments from the audience? Yes, got one here.
When you both teach us the lateral approaches, you convinced us that the most important thing was the positioning. And you told us that lateral was best because all of the belly stuff is going to go away from our field. And so it has been. And our experience is great. We love it. But now this?
So you're absolutely right. The same thing happens again. So you position the patient on an OSI table with Jackson attachments, right? Hip pads, thigh pads, and a chest pad. And so you have the belly hanging free in the middle, so the abdominal contents fall forward, the retroperitoneal space opens up, and in addition, instead of in the lateral position, one of the things we stressed is working orthogonally, right? Working at 90 degrees. You can also do that in the prone position. So the approach and the entire procedure is done with the patient exactly directly in the prone position. So you're still working at 90 degrees. So we're still working directly orthogonal, and the belly is still hanging away. Really what I think we've done is taken the lateral approach, reduced the things that kept people from doing it, enhanced it through a change in the technique, and really made this procedure a lot more advantageous.
Yes, in the back here.
Similar concerns still about transitioning. One of the things that we've moved to in the lateral is flexing the hips, flexing the knees to relax the lumbar plexus. In this state, you're disallowed to do that. Does that complicate angled approaches at L4-5 and getting more extravagant in the lower areas of the lumbar spine?
Yeah, so a couple things happen. I think you're absolutely right, is that the idea was that we would flex the hips and then we would relax the psoas muscle a little bit. And what we found, and we have some MRI studies which we're starting, is that when you extend the hips, it brings the psoas muscle back a little bit. The second thing that happens is that the pelvis rotates slightly, and it actually becomes more advantageous to get past the iliac crest when you're in the prone position. So you gain a little bit in the iliac crest, move the psoas muscle posteriorly, and that relaxation of the psoas muscle has not been a problem doing it in that position. I think really the problem that people run into is extremes on either side, right? So too much flexion, too much cramped position, and then too much extension. And I think those are going to be the two problems that we run into. But it's not been a problem. We've done the first 100 cases. I can't tell you the numbers. The first 25 cases, 15 of them were done at 4-5. So it's not been a problem from that. Yeah.
Usually it implies hammering a lot, and especially when you're opening the contralateral annulus. How do you manage this? Just with taping, or because the patient may move a lot?
Yeah.
Or?
So I got to tell you, you figured that out before you ever did a case sitting in a room. It took me about 5 cases to figure that out. And the reality is, when we first started doing it, we had that exact same problem and almost abandoned the procedure because the patient would slide, right? So we fixed that in various ways. Number one, the ultimate fix, which we have coming, is a bed and attachments, which sort of like a clamshell that fold over the patient and hold them in position, and then also rotate so you can get coronal correction and opening of that at the same time. At the moment, what we're doing is taping the patient and putting in bolsters. They're like borrowed from hip surgery, where we put bolsters in against right up against the chest wall and against the right against the femoral head. So we hold them in place with bolsters and taping, but I absolutely agree with you. The ultimate solution is going to be a change in the bed, which is not just going to hold the patient in position, but be able to move coronally to give you some correction and some easier access. Luis, anything to add on that?
Yeah, one thing that I have to add to that is a technique that you hear here and make sure that you don't repeat at home. Because it is not, it looks exactly the same, but we work against gravity. So that's another factor that we have to address. So we have a special technique to hold the retractor in position, as well holding the patient. When we use cob and rasp, etc., we move a lot of the patient, but that's why we fix the patient well in the Jackson table, make sure that we gain a good lordosis. By the way, the lordosis is much better than our previous lateral.
But I do think you've identified the exact problem that we face pretty quickly, and there is a solution to it. But it's definitely something which you need to learn, and technique, and before you try and do it, because you'll have problems.
You know, a lot of us are becoming really good now at single stage in a lateral position. You know, you can do multiple levels. As a matter of fact, if you do a direct decompression in the lateral, it's almost easier than doing it in prone through a tube, if you have to do that in addition. So it's going to, I mean, I think what you're saying is totally attractive and sounds really, really exciting. But it's kind of funny that now we're, you know, we're really getting good at lateral single stage.
Yeah,
and
I would agree with you. I mean, I think the single position idea was trying to get past the hurdle that a lot of people had for not doing lateral. So they said, I don't want to flip the patient, I don't want to do this. And that really was the impetus for this, is how can we do that single position surgery you're talking about? Right. And the prone position is much easier to do that in, I think.
I assume there's a company associated. It's not like you used your lateral and just flip the patient now. I have a strong suspicion that It's attached to a company,
Yeah, I mean,
right?
I can say, Louise and I have been working with Alpha Tech Company. We've developed the bolsters and some retractors and other stuff and a lot more to go. This is sort of in its infancy, though. I mean, this is not something which, 100 cases is great, but it's not 1,000 cases.
Right.
So,
Well, it's certainly exciting. We have another comment or question?
Tom Kristenitz from Virginia. In the lateral position, whether you come from the right or the left side, was various factors, concavity, convexity, osteophytes, the size of the psoas. Is this going to the prone modify that decision in any way?
it hasn't made any difference to me. Louise?
No, zero. It's still lateral.
All right, well, thanks, Bill. We'll move on. Luis is going to talk to us about how to achieve excellence in lateral surgery.
I hope I can convince you.
ICP, IPC.
So this is the doc. Okay. How to achieve excellence? First, understanding the anatomy. And it looks like, as Bill start talking, that we have a different anatomy because we go from the side. Actually, it's not different, it's the same, but we are not used, most surgeons are not used to the lateral position anatomy. And a little bit of indication because bad results start with bad indications. In my opinion, instability stenosis are the best indication for fusion, but for lateral procedure itself, I think spondylolisthesis and degenerative scoliosis are the main indications for this procedure. We have a lot of different indications like this and revisions, etc. But a little bit on what's important pre-op understanding. One of the important things is looking after the psoas anatomy and check if the psoas is not hanging anterior like a Mickey Mouse, because that's a transitional level. It's not a good indication for lateral procedures. Also, the facets are critical, as we discussed before. So the three goals of fusions are decompression, preserving sagittal alignment, and promoting fusion. To promote fusion, of course, we need a big, good, as big as better discectomy and end plate preparation is the ideal procedure. The best fusion comes from that stability. And if we cover the end plate more than 60%, we have a better fusion, better stability. Also, how we avoid subsidence. So we did several studies in standalone technology, XLIFs, and we found that older women, spondylolisthesis and degenerative scoliosis are contraindication for standalone. So we have to avoid them. The second goal of fusion for surgery is alignment. And we know that anterior procedure is better than posterior procedure in general for alignment. And restoring or maintaining the segmental lordosis is key to prevent adjacent level disease. We know that when we do this, when we don't do this, we have 10 times more risk to have adjacent level. So TLIF is a bad procedure. With these procedures, lateral procedure, we also learned that lateral in lateral, when we keep the ALL intact, we gain in between 3-4 degrees per level. When we do this in PTP, in prone, by the position, we can gain, as Bill described, double at least. That's an important difference, but still is lateral procedure. So it's really very important to maintain the segmental lordosis to achieve a good result. And decompression, what about decompression? So we discussed a little bit of indirect decompression. Direct decompression, we need to have good facets, to slide the facet, stretch the ligaments and bring the prolapse of the disc inside. And we did studies, prospective studies, and this has been repeated several studies, including one in New York by Eric Elowitz, showing that indirect decompression happens. Happens always? Doesn't. So it is very important to understand when indirect decompression doesn't happen, mainly bad facets, but also the bony stenosis, the posterior element that can bring problems. What we did recently is that between our recent, I don't know how many years we studied, 4 or 5 years, and even excluding the bad contraindication for indirect decompression, we had 4.6% of cases in the gray area that we had to come back and decompress directly, which means that if we do this in prone position and we have doubts, we immediately do direct decompression. And a little bit of how I do it. This is a trick for L4-5. We know that the 4-5 plex in the 4-5 level, the plexus is more anterior, and one of the way to do this is going with your first dilator a little more anterior, but then you have less space for your cage and you have higher risk to open the LL. What I recommend to do is tilt the table and go under the plexus until you lock your retractor with a shim, and then you unbend the table before you start the discectomy. So this helps a lot to give more space to address a good discectomy in 4-5 and to have less risks. A little bit of the new option that Bill already gave a good talk. So here is what we recommended during the last 15 years. Flex the legs, blah, 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 release, make sure that the psoas get loose. But getting loose means also that the psoas covers more the space, bringing the plexus more anterior. When we do in posterior, because the psoas is attached to the hip, when we do this, and I want to show you better than talking, I extend the legs and I stretch the psoas more posterior. The psoas migrates posterior, and some studies from New York shows that uncovers 30% of the disc space. And here is, you see on the left, Braghini's X-ray in prone position, and you see the segmental lordosis, and the same guy in prone position, see the difference of the segmental lordosis in the same healthy spine. So the position itself allows you to, is the first step for a good surgery for better alignment. I will not touch on the advantage also to be safe, protecting the plexus. The new EMG neuromonitoring is working, and we think is working better. There are different ways to do lateral. Some cases I do sitting position, Bill, but most cases, because I'm short, I can raise the table and I have a good direction, and then I can comfortable doing the procedure. That doesn't take long. Anyway, it's a great new technique, and I hope to show you more cases in the future. I have some cases to show at the case discussions. Thank you.
Thank you, Luis. That was a great overview over the factors that you take into consideration when you're planning your surgery and what you're looking at. We published a paper recently looking at the failure of indirect decompression. And I think that's always one of the most puzzling challenges. How do you tell a patient before surgery that they're going to be symptom-free if you do a lateral operation, and you don't have to go back and do a second stage or whatever. You know, I think that's one of the really most challenging problems. And you published obviously about the significance of lateral recess stenosis, that is something that's frequently not adequately being decompressed, the facet joints and so forth. So how do you just choose a different operation then, or do you do direct decompression? If you have somebody with an overgrown facet joint and they have severe lateral recess stenosis, do you then decide to do a TLIF, or do you still do lateral plus a direct decompression? How do you handle that?
And the reason I still do lateral is because lateral is better. But it's better because it has a bigger cage, bigger end plate preparation, better lordosis. And I just add decompression and supplementation.
So you do lateral surgery and then direct decompression at the same time?
That's why we found recently that doing this position, in case I'm not sure that indirect decompression will happen, I do the lateral and do one side foraminotomy, for instance. In case, for instance, the patient has a white facet in one side and a questionable facet on the other side. I never know if this will happen in direct compression. And my data shows that it's not 100%. It still fails in almost 5%.
What about the, we talked about that, the material of the cage. Now, they're coming out with the titanium, the 3D printed titanium cages versus the PEEK or the titanium coated. Do you see a difference?
That's a great question. It's interesting because 18 years ago, I started doing this in Brazil with titanium cages. And at that time, I had 100% of subsidence and horrible subsidence, like fully subsided. The difference is that it's not only the titanium, it's almost a hollow titanium. It's 60% of air. So it's porous titanium.
The 3D printed.
The titanium, they are two different things. One is the 3D printed, and the other is shaped one over little tiny shapes, and they melt together, and it's more predictable because all the time the holes will connect one to the other. It's what the company says. So honestly, we don't have the answer for that, but looks like one is slightly better than the other. But the important thing is that's not only the titanium that changed, it's the full technology changed.
Well, I would say that, now, I mean, you published that and we had a paper on that. What's really important is not the height of the cage, it's the width, right? The snowshoe effect. And therefore, surgeons, and probably you also, you're more likely to use a wider cage than a taller cage, and therefore you get less subsidence. Isn't that one of the main reasons why surgeons are better now at this?
Oh, yeah.
Because they use wider cages, not taller. So you're not trying to hammer the biggest cage in there, but you're really trying to put a wide cage.
And we also learned that when you gain too much distraction, you have much more subsidence. It's the opposite, that people think that you need a tall cage for indirect compression. You don't need. You need a gain of 2 millimeters or 3 millimeters height.
Right. Yeah, I think that's really important. Any questions, comments?
Dr. Pimenta, when you see those locked facets,
You have to.
Andy Cappuccino, Buffalo.
Hey.
When you see the locked facets and you know that they're going to prevent you from getting sometimes even that 2 or 3 millimeters, are you ever open simultaneously in this position? Do you go to the back, take the facets down?
Again, this is a new procedure. I was in Bill's case that his residents start doing the posterior part at the same time he was doing lateral. So it's really possible to do simultaneous posterior and lateral procedure. I don't have that experience, but I would think that yes, you can do at the same time and more. If you think in deformity cases, you can throw your cage, do your posterior release, collapse, and maybe changing the cage and and placing another cage. So you can go back and forth because both incisions are open.
You could do bilateral, right?
And we could do
right, left.
bilateral.
You could do 3. I mean, you know,
Yeah.
you can do 3 at the same time.
Absolutely.
Right, left, and from the back in prone position.
Yeah, I
Just
never
as-
did that.
I-
Yeah, but I don't think this is a good
The
thing.
next step. I had if there's no other comment or question, now we had a Bill casually mentioned that you can easily use navigation for these cases. You know, we've been doing a study with 2D navigation now for lateral surgery. You know, the main challenge is that, you know, the stimulation, when you go transsource and you start stimulating and the whole body starts shaking. I just can't, I mean, I don't know how are there different ways of doing
that's a
this?
problem. You can't really fix that problem. I can tell you what I do technique-wise to fix that is that I place the dilator and the K-wire before I do the stimulation. And a lot of people look around and find it first. And what that means is lots of times I have to, number one, be careful that I'm docked right on top of the bone. There's not anything in the way, which is pretty easy to do. But secondly, I'll have to occasionally take that dilator out and reposition it because I'm in not a good spot. So to prevent that problem, I don't stimulate as I go down now. I place the shim and the K-wire first and then see what my stimulation shows.
So you pin the nerve to the disc first with a K-wire.
You
and then
really
stimulate.
can take that first dilator and get it right down on top of the bone. And I don't put the K-wire in until I know I'm right down on top of the bone. Now remember, you still have free run EMG during that time. So if you hit a nerve or you do something, your free run EMG will go off. It's very, very sensitive to that. It's very sensitive to manipulation or compression of the nerve root. The problem with the EMG is it's not specific, but it's very sensitive, and it'd be very rare that you're going to hit something and not pick it up on free run EMG.
I'm sorry, so you're putting in the first dilator, you stimulate while you put it in, but that's where all the
I
shaking
stimulate, and then I dock it down, and then I put the K-wire in, and I do the final stimulation when I rotate it around with the K-wire in place, so I'm already locked into a position, and it doesn't jump around as much.
All right.
But I do think the navigation piece will be a lot easier because I found it difficult to use navigation with a person in the lateral position.
And you do 3D navigation or 2D for these?
2D.
2D. So you update you can update your X-rays frequently.
Yes.
Yeah, while you're doing it. Yeah. All right. Great. All right. Thanks, Luis. Thanks, Bill. We'll move on. We'll have Shiraz. Shiraz Qureshi is well known to most of us, of course. He's a real pioneer in MIS surgery. And he's going to talk to us about the procedure that Luis Pimenta loves the most, MIS TLIF.
No, I don't think this is the right. Great, so I'm gonna start, maybe you can.
Yeah.
Thanks, Roger. Thanks so much for having me. It's gonna get my laptop set up because I guess our videos weren't working.
Can we get this?
I don't think it's the right.
Doesn't fit.
No, I don't think it's the right. Do you want to do the next talk first?
Yeah, we can do that.
Yeah?
Yeah.
Sorry, maybe Roger, can we do the next talk while they're figuring out the technical details?
Sure. Well, is Greg? Yeah. Greg is ready. That was an easy battle for Luis to win.
I was gonna say kind of crappy surgery. I'm ready. I am ready.
You made our point.
So Greg Mundis from San Diego, of course, he's going to talk to us about anterior column release. Thanks for being here.
All right. Well, thanks for having me. It's actually a very much an honor to be here and spend some time with you guys here in New York City. It's probably my favorite city on earth, and even more so getting to hang out with Luis a little bit and Bill. Even though Bill and I live in the same city, we tend to only run across each other when we're about 3,000 or 4,000 miles away from home. So, and these are gentlemen that have really pioneered the surgery I'm about to talk about, along with Dr. Behrouz Akbarnia, who's my senior partner. Anyways, just again, thank you for having me and for allowing me to share this morning or this afternoon now. For me, it's still morning. We just flew in this morning. So here are my disclosures. So what we're about to talk about, let's see if I can get the sound going. Is there a sound button here? So I'll just, there we go. So basically, a lot of people think ACR surgery is a little bit like this guy, where it's only for the select few, no one can do it, it's so hard. It's just a really hard way to do something more simple. The bottom line is, hopefully I'll show you after today, there's a long track record of what we're doing, and hopefully I'll give you a little bit more confidence that this is a technique that, when done safely, can certainly be used in your practice. So hopefully we'll make that call for you today. That is not at all what an MIST lift looks like. Okay, so I actually have a lot of canned talks about ACR, and this one actually brand new. And so I'm actually excited to share. I just finished it like 10 minutes ago. I put it together a little bit differently because I put it together a little bit like train of thought rather than here's just to talk about the procedure itself. And so I basically used a timeline to kind of walk through how this procedure was developed. I know I'm going to miss stuff, and Luis is going to come up afterwards and nail me for it. But please, Luis, fill in gaps afterwards because you've been instrumental in so many of these. So this is Dr. Akbarnia's patient in 2005, and he was doing a lateral surgery, and he sort of serendipitously would say released the ALL, and something very interesting happened. And where he thought he was just going to do the front part to release and do some fusion, what he realized when he did it, he got about a 50-degree change in the segmental alignment at one disc when the patient had a segmental kyphosis. And this sort of sparked a thought in his head like, oh my goodness, this could actually be something more than just an interbody fusion. Perhaps we can really treat sagittal plane deformity with this. And so this was sort of the first case that got our tail spinning. Sadly enough, this patient actually has a C2 to pelvis now, ultimately. But I think interesting in the sense that we realized there may be less invasive ways to do this operation. So we're going to skip ahead for a year, and this is when Bill and Luis published this paper. And this was a landmark article. It's one of the most highly cited articles, and it involves just describing this approach from the lateral transpsoas, and really was instrumental in saying there's a safe way to get through the psoas to do an interbody fusion with a large interbody device. A lot of the data that came out of the next 3 years, and we're going to skip to 2009, was really centered around the lateral approach more than it was centered around any type of deformity correction. There were a few little deformity papers in there, but nothing really looking at the sagittal plane. And in the meantime, what was happening is that these cases were happening. And I did my fellowship in 2008. This happened in 2009, still during my fellowship. One of Dr. Akbarnia's patients that I helped treat, but we recognized a segmental problem here. The patient had some segmental flattening. You can see the PILL was off, the SVA was off, and if you look closely on these scans, you can realize, all right, there's dynamic spondies, there's error in the disc spaces, and this patient has flattening from L4 to S1, and it needs to be realigned. We did that through TLIF at L5 S1, and then a 4-5 ACR, which is not at all how we should treat this nowadays, but recognizing that this was one way of doing it. This then grew, and this is one of my early cases. This is his post-op films. This then grew into the next sort of sequence, which was, okay, if we can do it at one level, maybe we can do it at multiple levels. And so this is also 2009 still. It's one of my patients that had a previous 4-to-1 fusion, has some thoracolumbar kyphosis, but then has a fairly high PI at 71, needing to accommodate at least 30 more degrees of lordosis. This SVA was grossly positive, and so I thought, hey, instead of doing some more more invasive corrective maneuvers at L4 or L5, like a PSO, let's see if we can get the rest of it done just by doing multi-level ACRs above it. So we did 3 of them above that. Notice only 1 screw in each of these, and I will address that a little bit later on in this talk. And then here's what he looked like in between stages. Got it better, but not totally right. And we decided to do a long posterior construct to fix it. And this is what he looked like immediately post-op. And mind you, was actually very happy for about a year, and then took a downhill turn over the course of the next 2 to 3 years, and ended up actually in year 3 breaking his rods and needing a revision. So we go ahead to 2011, and we're getting a little bit more confidence in these procedures. Still not really any publications on this. So these are mainly just clinical experience that's happening before this time. Mind you, we're about 8 years ago now. And so this is a patient that came in, multiply operated, and see the mismatches that exist here. A patient has actually lordosis in her lumbar spine, not even kyphotic. Sorry, not lordotic at all. She's totally kyphotic in her lumbar spine and has a significant mismatch with the high CSVL. And so this is the first time that I was able to document this via video. And so I've shown this video quite often on how to do an ACR. And basically the way I think about it is I do a regular lateral, and then at the end we just cut the ALL and then dilate it up and then put in a larger lordotic implant. And you can do it at 1 or multiple levels if you need to. And then you can see just the same process happening here. Mind you, I'm a minimalist when it comes to disc prep. I use the cob a lot. I hardly use the pituitary at all. I use a box cutter, and you saw the knife just go in there, and this is popping it open and then placing the inner body again. At this point, still using 1 screw, and I'll talk again about that here in a little bit. So this is what this patient looked like. This is what she looked like after her stage in between that had her final construct there on the right-hand side. Mind you, it's not a standing film, but there's a reason for that. And I don't see it on my slide here, but maybe it's coming up in a little bit. I bet it's coming up. I'll show you the end result, which again led to a revision. Because our understanding of this implant really wasn't mature enough, and the understanding of the sagittal alignment wasn't, I believe, mature enough. So this is sort of our first attempt at bringing something to the academic circuit. So this is a poster at IMAST showing us our first 17 cases. It took us a couple more years to end up actually publishing it. But that, at least we were making the attempt to collect our data and go from there. In 2012, we really started training surgeons a lot more. It's Dr. Kleinberg, Alex Shen from at that time from UC Davis, as well as University of Washington, coming down to train with us. So we were starting to grow and thought maybe we can use these ACR techniques not only for sagittal realignment, but maybe it's more of a global realignment. I thought I had 20 minutes. I don't have 20 minutes. Oh, this is a much longer talk. All right, so we're going to blaze on ahead here. So here's our intraoperative x-rays there. And so mind you, now we're sort of treating 3-dimensional deformity by releasing the anterior spine. And here's the pre and post. This led to a few more analyses where we're looking at finite element to see what we can achieve. This led to Luis's first publication. I believe this is the first series that was published through the HSS journal. And then Dr. Uribe following that pretty quickly after that, and then our series a little bit later, presenting our first 6 years of experience, again showing a substantial correction in the sagittal plane, but also reporting our complications, which happen about 50% of the time. And here's a full list of those complications for your perusal. We also presented this to the ISSG and said, listen, how does this compare to PSOs? So we did a study looking at PSO versus ACR, and this is that published report of that. We took 17 patients that had ACRs, 17 had a PSO, and we compared the two together and found that overall the ACR from an angular correction had very similar results to a PSO, and ultimately they did about the same. The ACR had a little bit better pelvic tilt correction. The PSO had a little bit better overall sagittal realignment. And then we published this several years later in 2017. So again, here's another patient that had both a segmentally kyphotic as well as scoliotic deformity, releasing it here and then having a good postoperative result. Leading us to 2014, we start looking a little more detail biomechanically. So we started doing some finite element analysis here and realizing that Well, if we put certain different degrees of cages in, we get different amounts of correction. So a 20-degree cage can give us 10 degrees of correction. A 30-degree cage can give about 20 degrees of correction. Now, that's based on finite element analysis. We decided to do a cadaver lab along with it and see what happened with that. And you can see here that when you don't release the posterior column, you don't get that much correction. So that's the bottom line. You can put a huge implant in the front, but if you don't release the back, you're just not going to get that much out of it. So this is just showing that segmentally here with the lordosis angle measurements as well as the posterior disc height. The bigger the disc height, the bigger the correction. So here's a 77-year-old male who had a failed L3 to S1. This is what he looked like before surgery. He was actually a previous SRS president. Here's his numbers. This is sort of how we plan these operations, so it's good to kind of see our thought process. We fix the pelvic tilt first, then we plan it. This is what it would look like with an L3 PSO, which actually looks pretty good. This is what it looks like with an L1-2 ACR, and here's the 2-level ACR, and that was what he kind of would need. I told him you need to have a PSO, and he said, I'm not coming to you to do a PSO, I'm coming to you to do an ACR. So I said, all right, let's try it out. So here's the correction that we were able to attain on the table with a 2-level ACR. Here he is in between stages, and then here he is with his immediately following the second stage, and then here he is 3 years post-op having a durable result. 2015, we're going to more severe deformities. Mind you, I think the best thing that Luis said today is poor patient indication is the best way to have bad outcomes. And this is a patient that was on way too many drugs, had way too many problems to begin with. We started using the 2-screw technique here, mind you, having a nice correction. I showed you these extras a little bit before as well, but unfortunately, if you look here, we end up having to revise her because we built in way too much lordosis. She got PJK acutely, and we had to fix her there. So again, understanding where lordosis needs to happen is absolutely critical. So we decided to do a multi-center study here, looking at 4 different centers, pulling our patients together, realizing that across the centers, we were doing a pretty good job getting somewhere between 20 and 30 degrees of correction per ACR. We looked at our risks in 2017 of having these. I skipped the case, but just to realize that the lordosis correction, PLL mismatch improvement, and pelvic tilt were all durable over time, but also to show that the motor weakness that we saw early after surgery actually resolved in the majority of our patients, and the sensory changes that happened in 20% of our patients actually went down to 0% at 2 years. So these are at least data that we can use with our patients, showing that we have good radiographic improvement and that the neurologic issues that we have are typically self-limited. In 2018, we came up with a classification of ACR, and just to run through these real quick, a grade A basically means you did the ACR with no posterior release. A grade 1 basically puts a Schwab 1 osteotomy with it, which is basically a facet release. Type 2 is a facet resection along with your ACR. Type 3 and 4 is with a grade 3 and a grade 4 PSO along with it, depending on what you need. And this is this case where he came in before surgery, looked like that, had a non-union at L3-4. We went in from lateral, took the TLIF out, did an ACR, flipped him, and did a MIS PSO. And you can see this whole case was done through basically percutaneous approach. A type 5 is when you do a corpectomy for the purposes of your ALL release, as you see here, which kind of brings us up to date. Where are we now? And so a lot of what's happening now is biomechanics and trying to understand really what we need to do here. And so the group out of BNI has been very instrumental in showing us what we need. But basically, 2 screws are absolutely necessary when you do ACRs. Ultimately, if you really want to do it right, you should use a 4-rod technique to put the lowest rod strain on your construct. You can even do this minimally invasive, so you don't have to necessarily open them up to do that, but just realize a 4-rod construct is much better. The Italian group here, another Brazilian group showed us that the biomechanical strain here with an ACR is best treated with multi-rod construct. This group here recently out of combo out of BNI and Pittsburgh showed us that their PJK rate with ACR was 20% and their PJF or revision rate was about 11% for these patients. And they realized basically that the PJK increased with crossing the TL junction, sagittal imbalance severity, and overcorrection in the elderly. And when we overcorrect these patients, they just have a tendency to topple over. So here's our first report of looking at patients that had both ACR and a PSO. We did it both in cadaver as well as in clinical model, but the bottom line I want to show here is that we have very substantial improvement in the sagittal plane deformity by combining the 2 approaches. So when you need to, combining ACR with PSO can be very, very effective. Just realize that these are very invasive operations, even if you're doing them through smaller holes. And then looking at rod fracture rates, we've now identified that we even get rod fractures. This is just at 1 year, you have about a 4% rod fracture rate. So this number is only going to climb as we follow our patients out. So just to finish it up, here's a patient, 72-year-old female, 3 previous fusions, complains of both SI and back pain. It's kind of what she looks like, has air in her disc at L1-2. You realize that she has a lot of mobility at that 1-2 joint and with some end plate irregularities. Basically, again, what we do on these patients is we take their pelvic tilt, normalize it according to the pelvic incidence. So she ought to have a more normal pelvic tilt, like a 15. So we do that, and you realize that she's actually hiding her sagittal plane deformity quite a bit. That's what a L1-2 ACR would look like, but that's actually not what happens because an ACR never fixes the pelvic tilt. It only changes your overall postural alignment. So this is actually what would happen, and we definitely do not want to create that, which is all the PJK I showed you earlier in the talk. It's because we're doing upper lumbar ACRs and not creating our harmonious spine. If you do an L3 PSO, it sort of looks like this. And so what we end up doing is something, it was a little bit of a combination, which was we did an ACR at L1-2 to neutralize the kyphotic segment, not to do a full release. So this was on that grade that we used as a grade 0. So it was an ACR only without a posterior release. Basically what that did is it neutralized our segment at L1-2. It didn't really affect the flat back at all and didn't affect the tilt. And so then we go to the back and we do the MIS PSO, just kind of showing you how we do it. We get our anchors placed first with wires, do a midline approach for the PSO portion of it, where you can do your laminectomy and facetectomies. And then place your spoon retractors if you like those. I don't use them anymore. But you can place them there and then use a box cutter to actually do the osteotomy. Place your temporary rods that end up being the small little rods that sit deeply to your deep ones. Finish the PSO off, compress it down, and you get something that looks like that. We get your angular correction. And then basically you want to make sure you measured out and achieved the lordosis that you were planning for. Finish placing your anchors, pass your other rods, and then you'll end up with something that looks like this with multiple stab incisions on the back. And here she is at 3 months post-op. So with that, I guess I'll just say we don't want to be like this guy. You want to have a good team around you when you're approaching these operations. You want to do it thoughtfully and carefully. You don't want to have any hiccups in the process. This is the first time you're doing an ACR. You sort of feel like this. You're on an island. You're alone. You don't have anybody you're talking to, and so you gotta make sure that things are right. And so if things aren't right, you need to reset and start over again, because otherwise this whole thing can end up very, very poorly for you. So with that, I want to thank you guys. Sorry for going over a little bit, and appreciate your time.
A pretty amazing talk and almost a little bit threatening. It's very complex, there's a lot of thinking that goes into this. Are we at the point, is that really something that should be done by all surgeons, or is this something that should really be done by specialists and centers,
It's probably likened a little bit. It's probably.
You said initially, oh, it's so easy. You showed the video. But I don't. Is that really the case?
I think the bottom line is what Luis said. If you have bad indications, you're going to have bad outcomes, and I believe that wholeheartedly. And you can see some of the cases I showed you were not indicated for an ACR. We just had a cool tool that could give us a lot of lordosis. We thought that's all that mattered. And the reality is that's not how it works. So I think the indication is the most important thing, understanding where you need the lordosis and then going after it. The one slide I didn't put in here is just talking about how many of these cases I do. I do probably somewhere between 5, maybe 10 a year. All right. Uncommon for me to need this operation. And we talk a lot about it, and I'm on the podium a lot about it, but the reality is I'm not doing it that often because it's really not that indicated. Now, I will tell you, if you are an experienced lateral surgeon and you're very comfortable in that anatomy, then this approach is just one step further and is not that difficult to do. I would definitely encourage you to do the right training, have the right mentors along the way. And we'll talk a little bit about mentorship tomorrow. Have the right mentors along the way, in like Bill and Luis and Bob Eastlack, who's in the room here as well, Juan Uribe, et cetera. It's critical. Think through it. Go to a cadaver. Do it on there. Understand where the pitfalls are. And then it actually is, I think, a very safe operation. Yeah.
Thanks. Yeah, certainly should have given you the 20 minutes. I'm sorry about rushing you through the talk, but go ahead.
Just could you describe what's different that you do when you do the ACR release? we all know how to do the lateral approach, but what else is there on?
So the exposure is critical. So you have to be posteriorly docked in the disc space. If you're only docked at the 50-yard line or 50% line, it's not a good ACR because you're going to leave all this annulus posterior to you, and it will not open like that. It will open like this, and it'll basically crack the end plates. You'll fracture the annulus is too strong. So you have to be docked posterior. That's, I think, probably the most common mistake I see when it happens, and they're like, why did it break? They're not docked posterior enough. The second is being able to be comfortable with an anterior exposure where you're able to put a retractor and sequentially dilate your retractors larger so that the final retractor that you use is actually quite wide and spans the entire disc space. Because if you have that and you can look in there and you can see that adventitial space, then you can actually make your cut through the ALL without any really much trauma.
So you put up something to release that and cut through.
Yeah, so that the retractor goes anterior and then you cut it with a knife. There's different ways to do it. You can cut it from within. The ALL has 3 different layers. I didn't get into the anatomic data really, but there's 3 layers to the ALL. Basically, if you release the innermost layer, that's the most critical one. But if you can release the inner 2 layers, then it'll actually open up quite a bit because the outer layer of the ALL spans 4, 5, 6 segments at one time. So it's actually quite flexible. It's that inner layer that really keeps you tight.
And the pre-op planning, obviously, the imaging is important. What are the red flags for you not to consider in terms of vascular anatomy?
Yeah, so if you're doing an ACR and a lordotic spine, be careful because the vessels are going to be plastered more towards the spine itself. If you're doing it at the level of where a spondylolisthesis is, I would be careful. L4-5, if you are not a very smooth surgeon at 4-5 and very quick, I'd say if your retractor time is more than 10 minutes, 12 minutes, I would not recommend doing an ACR. I don't remember the last time I did an ACR at L4-5. It's been a long time, mainly because about 50% of our quad palsies were from an L4-5 ACR, and I just got skittish and said if there's a different way to do it, then I will do it. So,
What about calcification?
Calcification, I have not run into that being a problem. I don't know if Luis, you want to add to that, but I've not had an issue with the aorta being calcified.
Yeah, I have this question all the time, and the concept of the calcification, the risk of calcification of aorta comes from ALIF, and ALIF is a very different procedure that requires retraction of the aorta. And in this case, we don't touch the aorta. We just protect from the aorta, from the anterior vessels. So, by the way, as lower the ACR, we do better the correction. So, in my hands, I try always, if I can, do the ACR in 4-5, which brings a higher risk, let's say, higher. It's not so high. I never open a vessel so far. But the key is to learn that the distance between the anterior vessels and the ALL is the lowest distance is in 4-5, is basically small. 3 millimeters. Everything else superior is very, very safe.
And Luis has a nice paper on that, by the way. It's a very nice anatomic paper with great diagrams. Get it in color. It's worth reading. So I don't love the idea. I love the idea of releasing the spine and then putting in the right size cage. And if that means going with a smaller cage and expanding it up, I'm totally fine with that. I don't love the idea of provisionally tensioning things and then releasing a little. There's just not enough room. And I think what we end up doing is hurting the violating the end plates more than you realize. So there may be, as I would say, jury's still out. But in general, I'm not a huge expandable guy.
Two things. What do you think about the now changes in the indications related to tailoring the mismatch of lumbar lordosis and pelvic incidence to the age of the patient, that these recent works? And the other thing is also comment on expandable technology, because what I found easy now with expandable cages is just to open a little bit the anterior ligament and then slowly, gradually open the cage, and the ligament breaks. so you don't have to go with the knife and it's easier. What do you think about this, or you don't like it?
I don't like it because the ALL has to be cut. Like it doesn't just release. Something else will release, whether the bone breaks or something else snaps. Unless it's a really calcified, like if you have a nice calcified disc anteriorly, sometimes those will break on you, which are nice. Like those are the freebies. But if they're not calcified and they're soft, you have to release it. And then regarding your question about age adjusted, you have to be very conscientious of age adjustment. The other thing you should be very familiar with is your Russelli types of your spine. To understand where the lordosis needs to come from. If you don't know where it needs to come from, you'd have no business doing this operation.
All right, I think we'll move on, but transitioning now to the next talk. Do you do TLIF still?
Yes, actually, there's some new implants out that I actually like because they're huge. They get to like a 34-24, which is the size of a ALIF. So I've been playing with it a little bit more recently when I feel like the patient doesn't have a major sagittal plane deformity. Then if I'm doing an open posterior, then I'll just put this TLIF in place.
MIS?
I don't believe in MIS TLIFs.
Uh-oh.
Yeah.
Perfect setup. Perfect setup. All right, so I'm going to be talking about minimally invasive TLIF. These are my disclosures here. I think my biggest disclosure is just that I do lateral surgery. I also do ALIF surgery, but there are very particular times when I think a TLIF should be highly considered and may be considered the treatment of choice. So when is that? I think that this is the case that I have up here now is probably the ideal scenario for me to consider doing a minimally invasive TLIF. So it's a patient who's got a degenerative spondylolisthesis, L4, L5. As we just heard Greg talk about, there is an incidence or a higher incidence of nerve-related issues at 4-5. So in isolated L4-5 pathology, especially when there is radiculopathy secondary to mass effect from facet cyst, as is seen here, I think this is where an MIS TLIF really shines because it allows us to address this pathology through a minimally invasive approach and do not only an indirect decompression, but also a direct decompression. So what are we doing internally in an MIS TLIF? The first thing you want to do after you dock your tube is you've got to identify your facet joint. I think a microscope is a very valuable tool here, and so having the view with the microscope is key. We want to enter Camden's triangle. Obviously, the knock on TLIF is always that it is a very small space, as we can see here, lateral edge of dura there. We can see the disc space that we're working through. Once we've entered the disc space, preparing the disc space for an MIS TLIF can be challenging, and I think that this is because we're working through a small space and having to do most of the disc prep without direct visualization of what we're preparing, unlike an ALIF or an XLIF, that's where a lot of the pseudoarthrosis risk comes from. I think, again, where the TLIF tends to shine is that if you would like to do a direct decompression, you have the ability to go over the top, remove the ligamentum, see your entire dural sac, and in this case, after the cage is placed, in this case, and I know that Luis and I have talked about this in the past, where when I show this picture, there's a thought that expanding and getting height back or reduction of spondylolisthesis, that a non-calcified facet cyst should go away or burst. But we can see here that we put in the cage first and that cyst is still there. And I think that's in this type of a case where you still have a very tall disc space, it can become challenging. We're just reducing the spondylolisthesis alone may not get rid of that facet cyst. So I think having the ability to remove the facet cyst directly or any direct pathology that is impacting the nerve root can be very valuable. So how have we progressed? So, similar to what Greg just showed with regards to the ACR, there's been a true progression in TLIF. So this is what my operating room looked like in 2010, I want to say. You see a microscope, you see all the different tools, a tubular retractor, et cetera. But the biggest thing we see here is that we're looking at a fluoro that's draped into the workflow space here. So a fluoroscopically based TLIF looks something like this. So this is one of my cases that I did. And so this is not all of the x-rays we did, just all of the ones that were saved. And you can see that it is significant, right? So any minimally invasive surgery, you can see my hands there. You're going to see my fellow's hands in just a second, I think. And so there is a lot of x-ray that is being taken. So I think radiation exposure in minimally invasive surgery is a real thing to be concerned about. And when we were doing TLIFs primarily, and I think a lot of us continue to do fluoroscopically based, it is really surprising how often you can sort of just kind of say, okay, let me get another x-ray, let me get another x-ray, let me get another x-ray. And I think that is something that we need to be cognizant of. The other issue when we're doing fluoroscopically based surgery is that we can have some errors without realizing them. So this is a picture of percutaneously placed screws where you can see violation bilaterally of the L4-5 facet joints in an L5-S1 fusion. So I think understanding anatomy fluoroscopically can sometimes be challenging. It's not that it's not doable. This is a paper that we published kind of describing a technique to give you the least likelihood, at least from what we think in terms of violating the proximal facet joint when placing pedicle screws, but it is still challenging in certain anatomy. Guide wire placement, again, you can see a broken guide wire here, a really small interbody graft, a lot of things wrong with this picture. So how can we improve upon this operation, which I think most of us would agree does remain the workhorse of minimally invasive surgery? So I think radiation, as we talked about, is a big deal. I had published my own sort of radiation learning curve. And when we sort of, after 50 or so cases, I think we had normalized our amount of radiation exposure, and it was still a little over 2 minutes per case of radiation. So that is really significant when we think about sort of how many of these surgeries we are doing in a week, in a month, in a year. And so we really need to start thinking about three-dimensional technology. So I think navigation is not currently the standard of care, but as surgeons, we should all really try to push that it should become our personal standard of care, having some sort of three-dimensional technology. There are a lot of different options. Particular navigation that I like to use is a skin-based tracker, which looks something like this. And this is how we use it in a TLIF, where you can see that it's put on the skin away from the area of surgery so that you don't get any skin shift in the area that you're operating. You can see the view there. The 3D view is really outstanding. And the nice thing here is that you can still be on a Jackson table. You can use the Zeem to do your spin, so you don't need a lot of equipment. But the picture that you get, certainly is outstanding compared to what you may expect to see in a fluoroscopically based procedure. And then not only is it useful for placement of your Jamshides and ultimately your pedicle screws, but I think tube docking, tube trajectory, navigation can really become a part of your entire armamentarium of every surgery you do. This is a paper that we just published recently in Spine Journal that just looked at sort of the impact of navigation on MIS TLIF amongst other procedures. And if you look at the MIS TLIF, I think the biggest knock on using three-dimensional navigation that people tell me is that, oh, it takes too much time, but it only added 5 minutes of total time for us, and some of that was setup. But if you look at the amount of radiation dose, which you could see here, the radiation dose between MIS TLIF is really significantly reduced. And we can step away for part of this radiation, and also the fluoroscopy time is significantly reduced as well. Pedicle screw placement, we found that there was an improvement in accuracy of our pedicle screws and a reduction in the violation of the facet joints as well. How are we going to further improve on the TLIF? So I think the long-term success is really going to depend on achieving a successful fusion. We don't want to end up with a pseudoarthrosis like this. Again, one of the significant knocks on MIS TLIF is the fusion rates. We've really tried everything, and in my own hands, even using infuse and other allograft types of substitutes, it is very difficult to get a fusion, and you're dealing with other things like neuroforaminal bone growth. So while we're advancing in a lot of ways, we also have to go back. So I've gone back to taking iliac crest for all of my MIS TLIFs. We do it through a percutaneous opening like you see over here. We use a reverse reamer. You can get a significant amount of crest graft, which you can pack into the space and in the cage. We've designed some special curettes to really get all the way across through a unilateral port to do an excellent disc prep. And I think that this is going to provide with significantly higher fusion rates. And I can tell you anecdotally in unpublished literature, we have seen that. How about lordosis? So, again, everybody talks about TLIF being a kyphosing operation, and I think a TLIF done incorrectly, like this one that I did, where I left the cage way too posterior. Is it better than pre-op? Sure, but it's definitely not as good as it could have been. And I would say that there's still some kyphosis here. I think the jury overall is still out. There's not a lot of literature in terms of how to get good reconstruction of lordosis. Roger and I published a paper recently together that showed that expandable technology placed anteriorly in the disc space using the correct patient is very valuable. So you actually don't want to do this in patients who have high lordosis. And so when we use that, when we use those criteria, really try to get anterior in the disc space expandable technology, you can see that we can not only get excellent height restoration, neuroforaminal restoration, and lordosis, and this can be done at one or multiple levels. We've now recently shifted towards the use of a surgical robot. I think the biggest thing that we've seen there is that having the ability to preoperatively plan can be very valuable. This just shows sort of how long it takes, starting from the intraoperative planning to the screw placement, and it takes less than 15 minutes to put in 4 screws with intraoperative planning.
Symptoms
And I
are
think when
pain
done right,
in the right leg, numbness in the right leg, in the calf.
so this is a patient with a degenerative spondylolisthesis, L4, L5. We did an MIS TLIF, and everybody's really, excited about this, but this is meaningless. So I think where an MIS TLIF really shines is that it's a truly minimally invasive surgery, and you can, I figured, 12 hours of follow-up is what I generally like to keep it at. I don't want to see my patients for any longer than that. And at 12 hours, at least, I can tell you that they're all doing great. So I think it's a very powerful operation. I think that if you just have to be thoughtful about how are you going to get a good fusion rate.
Just the incision from the back. I have never felt this good in 12 years. Real.
On his way to the Aerosmith concert, as we could see. So thank you very much.
Shiraz, we're not done yet. That was 12-hour surgery, right? Not 12-hour after surgery.
That's right, exactly.
So thanks for your presentation. So any questions, comments from the audience? Yes, Luis.
I knew it.
Instead of criticizing, I want to ask a question. Can you tell us what's your trick to gain lordosis or to preserve lordosis in minimal invasive TLIF if you preserve one of the facets?
Yeah, I think that's a great question. So I have gone to getting CT scans in essentially all of my patients, whether that be preoperatively, outside of the OR or with the spin in the OR. And if I see that there's an opposite-sided locked facet, then I will drop the tube on the opposite side in order to make sure that I can get good height restoration and lordosis. I think it's really critical. I have found, I think that the newer technology can't overcome that. If you miss the fact that there is severe facet arthrosis, then you're not going to be able to correct it. But I think it's actually very similar to lateral surgery, because in lateral surgery, most of the time you are able to overpower spondylotic facet joints as long as they're not locked, and as long as you are thoughtful in terms of what you're doing. So I think placement of cages in the anterior third of the disc space is critical. I found, at least in my hands for an MIS TLIF, being able to use expandable technology can be very valuable in order to do this, especially a cage that will expand without compromising posterior disc height. So it's really expanding in both in the front and the back, but just expanding in lordosis, I think, can be very valuable. And then I think it keeps you honest on your discectomy. I think if you do a complete discectomy or a near complete discectomy, a unilateral facetectomy, for most patients, as long as the opposite facet is not locked, I think those are the critical things that you want to think about.
Yeah, let me just comment. Go ahead, yeah, please.
Chris Shaffrey published. Well, because my point again is that most of the minimal invasive TLIF is a kyphotic procedure. And because of that, Chris Shaffrey published a paper showing the difference of doing TLIF, taking both facets and really gaining good lordosis. And looks like
in a minimum invasive TLIF, you fight against two strong structures. One, the ALL, that is a very strong structure. You cannot, even using expandable cage, gain anything against the force of the ALL. Second, the facet allows you to gain posterior disc height, but doesn't allow you much to collapse because there is a limit on the posterior facet, right or wrong?
No, I think you're absolutely right. And I think that's why you have to be thoughtful in terms of how much lordosis you're going to get. I thought one of the interesting things in the paper that Roger and I published, what we found was that if you have a lot of lordosis going in, especially a 5-1, doing a TLIF can, sometimes you can lose a little lordosis there. But actually, if you don't have a lot of lordosis going in, TLIF can give you lordosis. Can it give you as much lordosis as an ALIF, especially when done MIS, as an ALIF or as an ACR? I would be the first one to say I can't get as much. And that's why in the cases where I'm really doing a sagittal balance correction type of surgery, and then I'm going to absolutely want to use the technique that's going to give me the most. But I think in the degenerative single level surgery where I want to get a direct decompression and I can feel like that the patient is sagittally balanced at baseline, I don't think a TLIF necessarily has to be a kyphosing operation.
Yeah, I just want to comment on that and basically saying very similar, but what Greg said before is really the key. It's patient selection, right? What's your target? What's the target of the operation? And the question is really what you're saying, Luis, is everybody needs more lordosis, or at least one of the main goals should always be to improve or at least not to lose. And therefore you come to the solution, you need, a more powerful operation. What we're saying is that not everybody needs that, but because some patients have different pathologies. But what we're saying though is if we define preoperatively that patient needs more lordosis, then TLIF is not the right operation. But it is still though an important operation in the armamentarium of all the MIS procedures that we do. Together with lateral surgery, with ALIF, with the TLIF is an important part of that, but it's not the solution for every surgery. It's only if the main goal is a adequate decompression.
Yeah, and I think I would just, and I totally agree. I just add that I think that the TLIF as a kyphosing operation, I would disagree with. It can be if done incorrectly, but so can any surgery. I think that as long as you do it thoughtfully, you can at least maintain and likely improve lordosis, but not as much as with other more powerful techniques.
Abelino.
I don't see a reason why if you say that the main criticism against MIS TLIF is that you only take the facets in one side, so you are not going to be able to give lordosis. But on the other side, if you do an anterior lateral approach, I mean XLIF, and you don't take any one of the facets, but then you are able to give lordosis. So I think you can achieve lordosis as long as you open the ALL, but otherwise.
That's right. So when we really need to gain lordosis in lateral, we have to take the ALL. And I think that when you really need to gain lordosis in TLIF, you have to take both facets, right? And my question is always, if L4-5 is 30% of pelvic instance, the pelvic instance is 60, can you gain 18 degrees in a minimum invasive TLIF?
Can you gain 18?
Maybe you can, Koresh, but 90% cannot.
Yeah, but that's preoperative. If you need to gain that many, then the TLIF is the wrong operation. We're not disagreeing at all.
Right. I think our time is up.
Yeah, thanks.
All right.
Thanks, Shiraz.
Thanks.
Great talk. So it's my pleasure to introduce Kai Fu, who is part of our faculty. He's obviously very well known in the deformity world and has done a lot of work with various societies on defining really the role of MIS versus open deformity correction. And thanks for being here. He's going to talk about less invasive solutions for spinal deformity.
Yeah, thanks for having me, Roger and Luis. This is not only my work, there's a couple people in the front row here who contributed quite a bit, or hopefully I do it justice. But I started as an open deformity trained surgeon, and I sort of have been transitioning to trying to find less invasive ways to achieve good outcomes. These are my disclosures. So we're increasingly recognizing spinal deformity in patients that come in. They may not be billed as a spinal deformity. They may come in as a foraminal stenosis or have radicular complaints, as this patient did, but also has a mild deformity. And this is not somebody that I think would probably be benefited to have a large open T10 to iliac with osteotomies. But this is somebody whose deformity needs to be taken into account when offering them treatment options. There's a high prevalence of scoliosis in the adult population. This has been well documented, ranging up to 70% in older patients. And we continue to be able to offer better and better options for patients. Older patients are now candidates. We have options for patients with lower bone density with some of the medications and some newer technologies. And we have more options for sagittal plane reconstructions as discussed prior, especially with the anterior column resections. However, morbidity remains high with a significant complication rate to open procedures. And these are sort of retrospective analyses of prospective data. So these are probably underreported, but we're talking 20% major complication rate at least in patients over 65. And then when we're doing big osteotomies, it's 80%, but really ineffectively probably 100% complication rate. So these are significant complications and significant operations to put people through. And like I said, big open operations can be necessary. They can entail significant muscle dissection, blood loss, complications we discussed, long operating times, higher risk of infection, long hospital stays. I know everybody talks about how their patients go home in one day. I'll be honest, mine don't go home, very quickly. And they often need extensive rehab. And then for not all patients can be candidates for operations that may make them feel better. So again, not every patient needs a T10 to iliac, in my opinion. And so the whole point of deformity surgery, I think, it should be you're trying to tailor your approach to what the patient has and offer them the best option for their specific deformity. So I started looking into MIS as I've been here with Roger for a long time. He kind of convinced me about the potential for MIS, less dissection, decreased morbidity, shorter recovery times, decreased length of stay. And now more candidates, I think, more patients are candidates for MIS or procedures for their deformity, whereas they wouldn't be a candidate for open deformity procedures. There are some concerns, of course, with MIS for spinal deformity. Number one is surgeon comfort with procedures. We sort of had in the past, but probably less so, two camps: MIS surgeons focus more on degenerative and deformity patient surgeons who did open operations, but maybe weren't as well trained in MIS. And I think that's changing. But again, you have to have comfort in both understanding deformity principles as well as MIS techniques. One of the main concerns is achieving arthrodesis in these long constructs. And then also the sagittal plane correction is a major concern. Again, sagittal plane deformity has been described, often requires osteotomies, or sometimes there's some newer advanced techniques to correct patients towards what we consider normal. And when we look at MIS deformity, its early applications, which were only about a decade ago or so, were really much better at coronal correction than sagittal plane correction. So at the time, around 5-6 years ago or so, the group with Mundus, Eastlack, Juan Uribe, and I, among others, looked at how do we discuss with people a rational way to approach applying MIS techniques to deformity patients. And really in 2014, when we published this, MIS deformity was limited to degenerative disease with a moderate amount of coronal deformity and no significant sagittal deformity. So anybody that required a significant sagittal correction ended up in class 3, which was traditional open procedures. But in the meantime, there's been a lot of advances in less invasive techniques. There's been a reinvigoration of the anterior approach, combined AP approach with advances in cage technology, especially in A-lifts, but also in lateral. And there's been advances in navigation, among other things, which make MIS a lot more feasible for many practitioners. And again, improved lateral access, as we discussed already, improved techniques, improved instrumentation. And as already mentioned, ALL releases gain more acceptance for certain patients that need sagittal plane deformity correction. Improved navigation and posterior percutaneous instrumentation. I am very new to percutaneous instrumentation. I never do K-wires. I just do unified procedures, and this is all due to newer and, in my opinion, much simpler instrumentation. Again, some of the tracking that I do in my multi-level navigated operations. So another change that's happened is that we've started to develop a more nuanced approach to the sagittal plane. When I first started, it was very much, there was a one number we wanted to hit for every patient for our sagittal plane correction. But over time, we found that that number changes based on your age and your overall sort of health and bone health. And so now we've basically found that sagittal plane correction does make a difference, but as you get older, that number becomes higher and higher. No longer does everybody over age 70 need to be corrected to less than 5 centimeters of sagittal balance. And that thinking is continually being addressed, and more nuanced publications continue to come out. So we looked at that one paper. Elderly patients who were not as well aligned, they did as well as those people who were aligned. And so therefore, those patients could be addressed with MIS techniques that maybe would not get them the quote-unquote aligned state that we traditionally would like them to be in. So at that point, we thought it was time to update the algorithm, went through with a bunch of the surgeons and discussed this using the Delphi technique. And we came up with this more newer one. It's just recently been published in the Journal of Neurosurgery. And this time we have 4 classes, ranging from class 1, which is very minimal deformity, class 2, which is sort of the moderate coronal deformity, and then class 3, which is the more advanced MIS techniques to deal with sagittal plane deformities. And then class 4 are traditional open cases. And again, this is a way of thinking about it. We're not saying if you have these parameters, you need to do one of these 4 sort of operations. It's really about where you are comfortable and what the patient needs. But this is a rational way to approach radiographic analysis of patients with deformity. So class 1 is a very mild deformity. I'm just going to breeze through this because I'm a little bit short on time. Class 2 is a little bit more significant coronal deformity. Class 3 is a patient who in the past would be treated open because of their sagittal plane deformity, but because of newer techniques, maybe be able to treat it with a less invasive approach. And then class 4 is your more traditional significant fixed deformity or prior operated deformity who would not be a good candidate for MS techniques currently. So then we went through and we looked at this algorithm. Was it reliable and reproducible? And the answer was yes. We had a very high kappa when every practitioner applied it appropriately, and we had a large number of cases with perfect agreement. So again, less invasive deformity techniques, as we will go through here, rely upon inner body techniques and having an open inner body space. And so this begs the question, which we just had a nice conversation on, which technique should you use and when? And I think that really depends on what are your goals. Are you talking about indirect decompression, direct decompression, sagittal plane correction? And so to further look at this, our group used 223 MIS surgeries collected over a 5-year period. And we looked at each level, what approach was used, and then what segmental lordosis outcomes were achieved. And so when we looked at this, we found that lateral approaches were preferred for foraminal decompression, for indirect decompression, and ALIF was generally used at L4-5 and L5-S1 with the greatest segmental lordosis change, much more significant than either TLIF or lateral L4-5. And then the most significant segmental lordosis was achieved at L2-3 and L3-4 with the few cases that were done with an anterior column resection. So again, it really depends on your level that you're looking at, your comfort with technique, and what your goals are. And so we're putting together, and this is in submission, sort of a way to look at each level, what options you have for MIS approaches for deformity. And this is just a way, a framework for looking at your options at each level. So again, the case that I presented initially, it was a class 2, and instead of doing a bigger operation, we did a 3-level lateral with MIS percutaneous posterior instrumentation. Some limits, as we talked about, and thank you.
Thanks, Kyle. It was a great presentation, great overview over the parameters that we're looking at in choosing the type of surgery. Any comments from the audience? Well, yeah, Greg.
Kai, ton of work's gone into this over the last 7 years, and we now actually have our first round of providing our data for our prospective study of looking at MIS deformity surgery. So I think the real data is actually still pending on how good we do, because most of what we did here is all retrospective. We all just grabbed some of our cases and tried to make them as consecutive as possible and pull them into a database, and the data is okay, but I think garbage in, garbage out as well is one of the threats that we have to this type of data pooling. But it's for sure the best we've had so far, and I think the one-year data that you're a part of is going to be super exciting because it's going to give us a much better clarity on how we're actually doing compared to those that are doing these operations in an open setting. The one thing I'll say is this is so surgeon dependent, and the other thing that's really hard that we're always complaining about is that everything lags about 3 or 4 years from what's published to what's actually happening in the operating room, because the techniques and technology are advancing so fast that we're not ever really able to study the technology we're currently using because we're just ahead of ourselves in figuring out those problems and fixing them again. How do you think we should go about educating folks on that and maybe helping people not go down the same error pathways that we have, and so they can leapfrog to where we are in 2020 instead of being stuck redoing all that over again, Kai?
Well, I think that's a great point. I mean, as someone who's transitioned from sort of open techniques to trying to use more less invasive techniques, and I wouldn't say I'm an expert, MIS surgeon, but over time, I think you can gain expertise in each one of these techniques, and you may start with a degenerative technique, you learning how to do lateral. For me, that was something I had to learn post-training, to MIS techniques, to percutaneous instrumentation. But over time, I mean, there's more and more adjuncts out there. As Roger has talked on for many years, navigation has improved to the point where it really it is very functional and can really help you transition from open to percutaneous much easier than in the past. And I think that overall, we've tried to put out with these algorithms, not a way for you to do things, but a rational way for you to think about how you can apply the MIS degenerative techniques that you have to these more advanced patients. And by no means, should you jump in and start doing deformity, but if you have something that comes up and it looks abnormal, maybe you can help, use one of our frameworks to think about things so that you can apply your MIS techniques in a way that will maximize the patient's benefit.
Thank you. Luis?
Yeah, I have to echo what Greg says, because when I see Praveen Umameni in the group, I think in algorithm. And those complex procedure, to have an algorithm and saying that 5.1 and L4.5, you do ALIF and you do ACR in levels above, for me doesn't make any significant, because first, it's all recent technology, and second, because those patients are so complex that you have so many other options, it's very, very difficult. I think I always see algorithm with criticism. What you think about that is basically an average of what people does, right?
Yeah, I don't think that I would tell you that everybody has to use this algorithm, but I think for the newer one that I presented, what it's trying to do is succinctly summarize some of the findings that we found from a multi-center group of what these advanced MIS deformity surgeons used at each level and what results with segmental lordosis only. I'm not saying clinical results, I'm not saying overall, but there's a lot of discussion. Well, I get 20 degrees with my MIS T-lift, but this one really showed that, even if you're one of the best MIS T-lift people out there, you're not getting that much. If you look at your, what honestly was put in. And if you're doing a lateral, you're not really getting that much. Maybe some people are, and there's outliers, but on the average, this is what you got with segmental lordosis at each level. And you can use that information to inform your choice. Now, if you can't do all the techniques, then obviously you can do the technique that you can do. But if you're thinking, well, I want to do the best at 3-4, well, the best result 3-4, according to what some of the practitioners in this group did, was a ACR, a lateral ACR. But that doesn't mean that that's the only thing you can do with 3-4, and there aren't other options for you. So I agree with you.
I just think the question sort of revolves around, the first thing you guys have done is get data, which is absolutely great. To have those patients and then to publish them and get the data, but to go from data to an algorithm and a specific protocol, that's, I think, where you run into a little bit of trouble, is you have data that you can interpret and you can look at and publish, but then to change that into a specific protocol for patients, that's the step which I think becomes really hard.
Yeah, I think, again, this is a group consensus, so I did not choose the word algorithm for this presentation. I think that definitely I would agree with you, it's a little bit of a misnomer. This is more of a table of your options at each level. So that's what I'd rather you take away as less of an algorithm.
Yeah, I'll echo that. It's not an algorithm. If there's anybody in this room that does any statistical work at all, you'd puke if you heard us say this is an algorithm. There's absolutely nothing about this that's an algorithm. It's a treatment pathway, right? It's like saying this to the best of our ability. These are like Kai said, they're treatment options. I really don't like that word. My statistician actually hammered that into Bob and I. She's like, these are not algorithms. I will also say that it is so surgeon dependent. You have to know for yourself what you're able to accomplish, period. If you don't know if you can attain something, then it doesn't matter what this piece of paper that was published tells you. If in your hands and your experience and what you're doing what you've done for your patients doesn't actually result in the desired outcome. So you have to be able to study your own patients well enough to understand where your own limits are as an operating surgeon. One of my favorite things to say is what's the IQ of the piece of PEEK or the piece of metal that you put in your patient? 0, right? It doesn't have a brain. Only we have a brain in the operating room. We have to make that decision. So it's up to us to get the patient dialed in exactly the way we feel they need to be dialed in. It's not the job of any screw or implant. So,
no, just in that regard, you guys have done a great job, as Bill mentioned, collecting data and then interpreting the data, coming up with analyses. Pete Angevine has a really nice talk, by the way, about the value or non-value of P, the P value, how insignificant that really can be. But the question that I have is, if you look at the patient in the office and you look at the X-ray, that's the big question mark here. We know everything. Once we know the X-ray, we measure the angles, we have a perfect solution for the surgery. The question is really who really needs those surgeries then? And you mentioned that you'd only do it 5 times a year. What I would like to see at some point is really a meeting or a conference about how do you make that decision in the office when you evaluate the patient. Is that patient really the patient who's going to need the ACR or the 10-level deformity surgery, or can we do just the MIS decompression or 1 level whatever, or no surgery? That's really the secret, and nobody has answered that. Once we know the X-ray and we know the angles, we're getting perfect now in terms of defining the surgical solution. The big challenge and the art is really still evaluating the patient in the office.
Boom.
Yeah.
That's a mic drop right there, Roger.
Thanks. All right, thanks, Kai. And so we'll move on, and we'll move on to the coffee break, and then we'll have 2 breakout sessions. We're going to have breakout sessions on different types of spinal fusion procedures. We're going to have one group upstairs again, the other group downstairs. The group upstairs is going to be with Kai Fu, and downstairs with Mike Verk. Those are going to be the moderators. And we're going to split it up by letters, last name, the initials of your last name, if you don't mind. So the first group up here, A to L, everybody with A to L is going to stay up here. And M to Z is going to be downstairs with Mike Verk. Doesn't matter.
Z will stay here because these are more crowded.
Doesn't matter. That's okay. So don't worry. So AL is going to be upstairs. MZ is going to be downstairs. And then we'll have the moderators there. And we'll meet back up here at 4 o'clock, 4:10 for 3D navigation. Thank you.